Hey, welcome to our RadPath lecture about liver pathology. My name is Matt Hartman from Pittsburgh, PA. I'm a member of AMSTER. Again, the full lecture can be found on the ACR building blocks. What I'm going to show is an overview, summary of what I think are the most important topics. And if you want the RadPath Anki flashcards, check out the About section on our YouTube channel. So before we do anything, we have to know the liver anatomy, the liver segments. I'm not going to spend too much time on this, but realize there is a system. I always remember segment 6, right posterior. The portal vein cuts the liver north-south, and then you have 3 hepatic veins separating it into right, left, and there are 2 central segments. Okay. How do we evaluate the liver? We can do ultrasound, CT, MRI, or PET-CT. We're first going to talk about diffuse liver disease, and we'll talk about cirrhosis. This is a nodular, lumpy, bumpy liver. Look for other findings like splenomegaly, ascites, varices. This is pseudocirrhosis. This is a patient who had breast cancer, got chemotherapy. Now it's lumpy, bumpy, a little bit of ascites there. So that can be a fake out. The other concept about diffuse liver disease is deposition. We realize the normal liver will have a Hounsfield units of about 60 on non-contrast. That has to do with the glycogen composition in the liver. But if we put other elements in there, we can increase or decrease that. So elements, metals like copper, iron, or iodine, if you remember, has a high atomic number, that will increase the hepatic attenuation. We put fatty substance, microscopic fat in there, that will bring it down. Let's see an example of that. Here's our normal liver, about 55 Hounsfield units. Look how dark this liver is. 10 Hounsfield units, very fatty. This liver, very bright, 130 Hounsfield units, a patient with hemochromatosis. So let's focus on fatty liver, seeing many more cases of this. Can divide into alcoholic and non-alcoholic. Very common cause of elevated LFTs. What's it going to look like? Well, if we remember ultrasound, the things that are bright in ultrasound, fat, air, calcium, and bone. This is the liver ultrasound of a fatty liver, very echogenic, hard to penetrate through. This is a normal liver. I can see the vessels, the parenchyma really well. So fatty liver, normal liver. MRI, we've seen this before, the in and out of phase imaging where we're looking for microscopic fat. This is the out of phase imaging. You get the India ink around the major organs. And this slide might look familiar from the adrenal talk, but look at the liver here. It's nice and gray on the in phase. You give the out of phase imaging, it loses signal. This tells us this is our stain for microscopic fat. What also gets dark is our left adrenal gland. This left adrenal gland has microscopic fat. This is an adrenal adenoma. So let's review. Fatty liver on CT, very dark. Ultrasound, echogenic poor penetration, and the MRI, we have that special stain where the liver loses signal on out-of-phase imaging. That can be focal and be a fake out. You might think that looks like a metastasis, but when we do our in and out of phase imaging, it loses signal. We just diagnosed focal fat, avoided a biopsy. You can go back and forth with the animation here. So now we have an hepatic lesion. We want to answer a couple questions. The first one, this should look familiar. Is it solid or cystic? So go back to the first RadPath lecture. If it's solid, is it hypervascular or hypovascular? And if the liver is cirrhotic, be thinking HCC. If there's biliary dilatation, think cholangiocarcinoma, and always think Mets lymphoma, especially if it's multiple. So here's a case, anechoic on ultrasound. 0 Hounsfield units, T2 hyperintense. These are hepatic cysts. Go, anechoic, got 0 Hounsfield units, T2 hyperintense. So now we have a cystic lesion that's not a simple cyst. It could be a cystic metastasis, could be a cystic neoplasm, such as a biliary cystadenoma, could be infection or abscess. So here is a low-density cystic lesion. 6 months ago, completely normal. So we're thinking something aggressive, fast-acting, could be infection, but this is a patient with ovarian cancer. This was ovarian mets. On this hand, we have an 80-year-old with right upper quadrant pain and fever. Cystic, I like this. It sort of looks like a cluster of grapes, a bunch of cysts around each other. And this is someone who had the fever. We're worried about abscess. It could be Mets, could be a necrotic tumor. Tissue is going to be the issue. We went in, we drained it, and got out about 50 cc's of pus. The patient felt much better. Fever went away. And so we remember abscesses anytime you have multiple cysts, that grape-like appearance. Don't forget that. Okay, but if we have a solid lesion, we will have a different differential. And again, we want to know, is it hypervascular or hypovascular? And we'll put hemangioma in our other category. So it's very important to know and understand the timing of imaging when we do a liver mass protocol, either CT or MRI. Let's see what I mean by that. So first we have a non-contrast, and you can barely make out this liver lesion. We give contrast, we're in the arterial phase, about 30 seconds, and note that we're getting some peripheral enhancement. Portal venous phase, 60 seconds after, starting to fill in. And then we wait 3 to 5 minutes, delayed phase, completely filled in. Give you a couple of seconds to think of your differential. But this is a classic hemangioma. I think of it as a bag of blood, and it can have a variable appearance based on its appearance, but this is the classic appearance where it fills in over time. This was actually from one of my RadPath students. Huge, huge lesion, but again, it fills in slowly on the later images. And this was the intra-op, and a big bag of blood when you looked under the microscope, a huge hemangioma. So now let's switch to the hypervascular lesions. We will detect these on arterial phase imaging. HCC is a classic one, especially if you have a cirrhotic liver. It will enhance on arterial phase and wash out. If it's multiple hypervascular lesions, be thinking metastases or multifocal HCC. So here is an MRI. Arterial phase becomes brighter, and on later phases, it's going to wash out. It's going to become less signal than the rest of the liver and gets a little capsule around it. This is classic for HCC. Another patient, again, note the brisk arterial enhancement. On the delayed, becomes lower signal than the rest of the liver and may have a capsule. These cases where it's classic like this, we can obviate the need for a biopsy. Our next hypervascular lesion is an FNH, often seen with females on OCPs. Again, we're going to do some MRI here. I call this the stealth lesion. On non-con, it can be very hard to see, give the contrast, and it lights up. And has a central scar, oftentimes. And we diagnose the FNH, which if we had diagnosed this preemptively, a lot of times this is a follow lesion. I can't remember if this patient was having pain or why they removed it, but regardless, we got a good RadPath specimen. Another classic case, arterial enhancement, central scar. But I'm telling you, on the other phases, it can be hard to see. So if you get a lesion that you only see on the arterial phase, be thinking FNH. Okay, how about this case? Again, we're arterial phase and we are seeing multiple lesions. Where it could be coming from? Well, fortunately, we watched the RadPath lecture on the kidney and we noticed that there is a solid mass coming off the upper pole. And if we remember our tumor tipping points, what do we want to make a comment on? Well, is there vascular invasion? Yep, going into the renal vein and probably the IVC as well. So better get the vascular surgeon to help out with this case. Okay, this is in contrast to this one where multiple liver lesions, but these lesions are low density. This is our classic colorectal cancer. Remember in the first RadPath lecture, this is a nice example of mass-like thickening. This was colorectal cancer going to the liver. So again, multiple lesions, is it hypovascular or hypervascular? This is one of my favorite cases. This was a case from fellowship, and we're going to apply the same principles. We have a CT scan, non-con, arterial, portal venous, and then delayed. And how is this lesion behaving? Well, it's not hypervascular, it's dark, but it's staying dark, maybe filling in a little bit. So it's not behaving like a hemangioma. And the other interesting thing is we have these dilated branching tubular things through the liver. Now, I'm going to tell you, we ended up biopsying it. This patient was as orange as a carrot, very jaundiced, probably the most jaundiced patient I've ever seen. And we had an inkling of what this was. Again, wanted to confirm it with tissue, but this is a large central mass, hypovascular with biliary dilatation. If you remember from the beginning, this is very suggestive of a cholangiocarcinoma, which it ended up being. Again, so we said it was solid, it was hypovascular, and then our trick, biliary dilatation, then cholangiocarcinoma. And this is a nice review of the different types of cholangiocarcinomas, either being intraductal, extraductal, and our case, right, the biliary confluence, this is a Klatskin's type tumor. Every Hartman differential, Mets lymphoma, especially if it's multiple, it might be thinking, hey, this is hypovascular, it looks pretty good for colorectal cancer, that's a great thought. But this patient, we biopsied it, ended up being lymphoma. Makes a huge difference. If this is metastatic colorectal cancer, it's stage 4. If it's lymphoma, it can potentially be cured with chemotherapy. So don't forget Mets lymphoma when it's multiple. So let's review. Questions you should ask yourself with liver lesions. Is the liver cirrhotic? Cirrhotic liver with a solid lesion is HCC till proven otherwise. Is your lesion solid or cystic? If it's solid, is it hypervascular or hypovascular? Finally, remember Mets lymphoma if it's multiple.